Hi, I'm David Levine. I'm co-chair of Science Writers in New York. Um, Behind the camera is, sorry, the other co-chair, Joseph Bonner. Our guest tonight is, our guest this morning is Muge Cevik. Dr. Cevik, do you want to turn your camera on? And the reason we're doing it this morning is that Dr. Cevik is in Scotland. She's a clinical lecturer in infectious diseases and medical virology. Sorry, her research interests focus on HIV, tuberculosis, hepatitis, emerging infections, and tropical infections in low and middle income countries. During the pandemic, alongside working on the front lines of the response, she provides scientific input to the Chief Medical Officer for Scotland on COVID-19 and serves as a member of NERVTAG, which stands for New and Emerging Respiratory Virus Threats Advisory Group, an expert committee of the UK Department of Health. So welcome, thank you for doing this. Turn your audio on. Okay,
thank you. Thanks a lot for inviting me.
Oh, you're welcome. I was reading that in the UK, in the United States, there are 27.9 million cases of the coronavirus, 490,000 deaths. In the UK, it's 4.7 million and 119,000 deaths. I could not find any numbers for, you're in Scotland, right? Mm-hmm. I couldn't find, they didn't break it down to Scotland or Wales or anything. So why don't you tell us about the work you're doing advising scientific input to the Chief Medical Officer, and also what is NERVTAG?
Yeah, thank you so much. So basically since March last year, I started to give scientific advice to the Chief Medical Officer here. Obviously, I was one of the many clinicians and researchers feeding in to the policy making. My main initial role was doing literature review and summarizing the emerging evidence. At the time, we had not much understanding, and the data was accumulating really quickly. But I would say initially it was unclear to many of us what was happening, but probably by April time, we had a lot of data coming from China and other Southeast Asian countries. So basically, some of this scientific advice fed into the policy, especially in terms of, in Scotland, obviously I'm not in the advisory group, but we've been closely working with the advisory group. Especially, I feel that we've been leading some of the policy decisions for the rest of the UK. Majority of decisions were first coming from Scotland and followed by other developed nations, England, Ireland, and Wales. Especially, I think we've been kind of leading in terms of like children, like making different policy decisions for children versus adults. Also, we've been kind of trying to make differences in terms of like outdoor and indoor activities. For example, outdoor activities have been much more kind of relaxed compared to indoor activities. We tried to exempt children from some of the outdoor activities. For example, they've been able to meet outdoors in parks with other children since July time. And yeah, I guess like some of these decisions have been kind of feeding into the policy. But as you know, policy making is so complex. It's not only about science. We basically, put the evidence together, but making that policy decision involves other parties. You need to kind of consider sociological perspective and finance perspective and many other things. In terms of our work in NERVTAG, obviously this group was already present before the pandemic. It was about informing the government decisions in terms of new emerging threats, and they used to meet like twice a year before COVID, but basically we meet every week now. And I was quite co-opted to this group for COVID-19. Our kind of main role is to kind of again continue to review other emerging infections. We still review the data about, for example, influenza or new variants, mutants. I guess like vaccines, transmission, and we basically feed into SAGE, which is the main advisory group in the UK that feeds into the government. So yeah, I mean, in our group, we have multidisciplinary team. There are virologists, modelers, clinicians, but sociologists. But our main role is basically to look at the scientific perspective. For example, we were looking at whether vaccines prevent infection, discussing about immunity certificates, for example, or looking at what evidence we have about the variants, and kind of also advise future recommendations as well. What needs to be done, what data sets needs to be reviewed, and we basically scrutinize all the data coming to us. So we see the data coming from hospitals, nursing homes, we look at the reinfection data. So it's like so many things. But I guess like since December, our main focus has been looking at variants and understanding, how that had an influence on epidemic trajectory and what needs to be done next. So it's a little bit, how I could say, it's a great honor and proud to be able to contribute to policy decisions. But the more I'm involved, I realize that it's just so complex. It's not only about science, and it's, scientific evidence is only part of what goes into policymaking. So yeah, there are so many people involved, and it's and I'm actually really glad to be working with other people. For example, we've been working with sociologists and aerosol scientists and epidemiologists, and I constantly learn from them as well. I hope that this is a good kind of summary.
It's a great summary. For the audience, if you have a question, please put it in the Q&A box rather than the chat box, because the Q&A box is where I'll be reading the questions from. So in March of 2020, Boris Johnson said that he was not going to let COVID change his habits. He was going to go shake hands with people. He was going to meet with people. And then he got COVID. Did that change the country's response? I mean,
it's like in terms of behavior, do you mean?
Well, in terms of, well, he started to take it more seriously. I mean, he's put people on he's put the country on lockdown several times. He's been much more vocally supportive than he was in the beginning. And so what has been the okay? So tell us about the British variant and why is it called the British variant? Because it started there, or the first cases were discovered there?
Yeah. I mean, I guess like in terms of your initial kind of comment, I guess like for many European countries, including the UK, maybe we've been a little bit slow to respond. I think in March, we were still not really comprehending the severity of what was, waiting. So maybe it's just been a little bit, slow for us to digest what was happening, because I was actually reviewing some of my Twitter kind of threads I've been doing. And the first one was from 23rd of January last year. We had a lot of data back then. And, some of that data and the knowledge we had hasn't really changed much now. So it's kind of maybe we just need to, this is just a reminder for us to be much more ready for, you know, emerging infections and pandemics. I remember having attended a conference in 2018 where Professor Drosten, Kristen Drosten, was talking about emerging pandemics, you know, pandemics and emerging infections. And he basically said that there are many coronaviruses that are likely to be causing pandemic over the next 10 years. And there are so many scientists who've been studying this. But I guess like it's often difficult to, you know, convince politicians to invest in something that they don't see, you know, close by, you know, because it's basically investing in future threats that may happen or may not happen. But overall, I think COVID-19 has shown us that we need to invest in kind of social care and public health. You can't just expect, you know, without any infrastructure, you know, without investment into these, you know, fields, and all of a sudden at the time of pandemic, you expect everyone to just do their magic. It basically requires long-term investment, especially, you know, social care, public health, routine diagnostics, also like preparedness for pandemics. Anyway, so just putting that aside. In terms of the variant, obviously it was first identified in the UK, and I don't necessarily like to call it UK variant, but it's been called like that, I think, several times. What happened is that in October time, Public Health England identified rising cases around Kent area. So this was around the time majority of you know, cities were under lockdown. Not necessarily like the March lockdown, but you know, majority of adult mixing was limited at the time. And while PHE, Public Health England, was identifying and investigating this outbreak, they couldn't really understand why this was happening, and they couldn't really link it to the behavior or seasonality, because it didn't really follow what was happening in the surrounding area. And that's when, that was around the time South African researchers informed a genomic consortium in the UK, saying that they identified a mutation and a variant that's much more transmissible. And basically, Genomic Consortium started to look out for it. And when they basically matched some of the epidemiological data with the sequencing data, we basically saw some correlation. So when the variant was increasing, the numbers were increasing as well, cases were increasing. So this is how it started, and it's by December, this variant dominated majority of cases, especially in Southeast England and London, and then it basically spread all around the country. But I guess like we don't necessarily know where it originated. I mean, it was first identified in the UK because we have very strong sequencing infrastructure. So almost 10% of positive cases are sequenced in the UK. I think the next country who does regular sequencing is Denmark and South Africa. And those were the countries who identified other variants as well. So I think what we learned over the last maybe 2 months is this variant has a fitness advantage, meaning that it will potentially become the dominant variant, probably globally soon. We had another mutation early in the pandemic that also became dominant quickly. So when the variant has fitness advantage, it will take over. But obviously, like having a more transmissible variant doesn't mean it will immediately, you know, cause the same thing we had in December, because, you know, transmission depends on many things. So it depends on the season, it depends on all the opportunities for transmission. So maybe in a way, I think we need to look at this way. Yes, variant is more transmissible, but also it was at the right time, at the right place for it to cause this sharp rise in cases. And that happened in the UK. But I guess we need to monitor and see what's happening in other countries. For example, in Germany and Denmark, now this variant is overtaking other variants. And we know that it's much more transmissible, but they're able to control their epidemic. So for example, the numbers in Denmark and Germany are coming down, probably much slower than expected. But what we are seeing is, these restrictions able to control even the variant. So that's a good thing. And the second thing is now majority of countries are vaccinating their, really high risk susceptible population. So, we had this variant at a time where we were already having the winter wave. And around the time we lifted the restrictions, around the time majority of population was still susceptible. So I think we need to kind of monitor and see what is going to happen in other countries and whether this, higher transmissibility of the variant will have an impact on the trajectory of the epidemic happening. I know that some people are very concerned about what's going to happen in the US, for example. I'm hearing kind of people talking about, for example, in Germany, that this variant is becoming the dominant one now, and whether it's just going to cause a similar kind of trajectory as we had in the UK. But I don't know. I mean, I think it may not be the same because, now people are a bit much more immune compared to December. There's much more vaccine coverage. Seasonality might have an influence, and obviously there are some restrictions. And what's happening in Florida is also interesting because variant is really dominant there, but the cases are still coming down. So I think we need to look at transmission as kind of a package. We can't just look at the, how the virus behaves, but, transmission depends on behavior and environmental factors as well.
So you have 133,000 followers on Twitter, which is quite impressive. Has that increased a lot since the pandemic?
Yes, it did. Yeah,
it did.
I mean,
okay.
I was doing science communication before COVID-19.
So one of our listeners said, "Could you share your experience with science communication as a researcher? What are the challenges of engaging with the public and policymakers as a scientist? And did you undergo specific training to be better prepared to communicate?"
Yes, that's a great question. So I guess it's quite challenging because I think, out of the pandemic time, people can be much more nuanced and balanced and kind of stick to the facts.
Mm-hmm.
But I think what has happened is, even among academics, I feel that it's so difficult to be nuanced in this really political environment, and also kind of stick to the facts, because I mean, I guess we're all human and we are also influenced by our own kind of thinking and worldview, and I guess what I've been trying to do is kind of stick to the facts, trying not to kind of allow my initial thoughts to affect how I assess the evidence, and how I communicate that to the public. So I think two things that I find really sad. I mean, as a science communicator, I've had a lot of training before, and I've actually been given training to clinicians and researchers before the pandemic about how to use Twitter for science communication and outreach, because I think it has a powerful effect, and and it can reach millions in a really quick, short period of time. The challenge is, I think, one, to be kind of objective and honest, and that seems to have been lost a little bit during the pandemic, because I think everyone's kind of initial thoughts or views have affected how they interpret the data. That's one thing. And the second thing is, I think I guess, like, during the pandemic, many scientists have joined social media, and they've never had any platform like this before. So I think seeing a lot of likes and retweets sometimes like reinforces your misjudgment, because there are always sides in this pandemic, unfortunately, and there's been a lot of dichotomies. I've seen this for school debate, mask debate, outdoor masking debate, everything, asymptomatic transmission, everything has been dichotomized. And I feel that because of that, some of the professional etiquette has been lost. And that's something that I basically tell during my training about science communication, to basically set the goal why you're on social media. I think every scientist and clinician needs to, or other people need to ask why they're on Twitter, because the thing is, it takes a lot of time. It's time consuming. Academically, it doesn't really give you anything back. And many people do it on their free time. So for example, for me, my main goal since the beginning, even before pandemic, has been, providing that scientific knowledge to the wider community and making that accessible. And that trying to keep that objectivity during the pandemic, I found really challenging. But I've seen many kind of, not really keeping that fine line between being a scientist, but also, being a huge activist and advocate of one part of the argument. It's just like, there's been a little bit imbalance, I think.
The other thing I've noticed is that the explosion of published articles in BioRevix and others is that, so these are not peer reviewed, but everyone is pointing to them as the source of new knowledge. I mean it's done by really good researchers, but is that something that concerns you, or?
Yeah, I mean, it doesn't necessarily concern me, but I think over the last year, those preprint servers have also kind of adjusted how they process things. For example, medRxiv now puts on the website, when you open a new article, it says it's not peer reviewed. And what does that mean? Because I remember around January, February time, we were still discussing what it means to have peer-reviewed articles. So I think many people now learned what that means. And also medRxiv and I think bioRxiv now introduced a screening process where they basically screen initially, not necessarily in detail, but to see whether that's a credible kind of research. But obviously, there are positive and negative sides of all those things. I think rapid sharing of data has really improved how our understanding of pandemic, and that's been a really great contribution. And we actually, if we haven't had preprints, probably it would have been really difficult and delayed that information flow. So I think we have much better understanding how we deal with preprints now, but I still see quite a lot of junk. But I think now the public knows that these are not peer-reviewed articles. That's a good thing. And I think journalists and reporters have also been quite, acknowledging this fact. And the third thing is, I think probably social media and science communication comes into play here. There's been a lot of, scientists, kind of debunking or peer reviewing it on social media, which has been quite good. Even, the articles that I put as a preprint, some of them have been, scrutinized on Twitter, which actually helped me to change it and update. And that's the whole point of peer review, kind of having the opinion of others so you can improve your own research. Yeah.
Okay. So the vaccine rollout has been disappointing, obviously. I mean, the United States, today, one major hospital chain canceled all their appointments. New York City says we're running out. What's the experience in where you are with vaccines?
So, in the UK, in Scotland, we basically started vaccination around beginning of February.
And you have 3 approved vaccines, right? Pfizer, Moderna, and the AstraZeneca.
Sorry?
You have 3 approved vaccines, right? AstraZeneca is approved. Yes.
Yeah. Okay. So at the moment, AstraZeneca and Pfizer vaccines are being delivered. And basically in the UK, we decided to delay the second dose so we could basically give it to much larger population in short period of time. And now there's actually data showing quite good vaccine efficacy after the first dose. And actually, if you delay the second dose of AstraZeneca, you get much better efficacy. If you delay it 8 to 12 weeks, you get much better vaccine efficacy. So I think it's going great here, but I think overall the number of vaccines we have available may not be enough, and there will be always, I think, discussions about that. But it's great that we now have like 7 kind of vaccines which passed through the phase 3 clinical trials. But I think the other aspect is, for example, we've been able to give the vaccine to the elderly population here. Almost like 15 million people received the first dose by now. And healthcare workers and people working in social care have also received majority of them. But I guess the challenge would be to basically, reach to the rest of the, medically vulnerable population, and whether it's going to be enough. And overall, how do we kind of balance the vaccine distribution versus lifting some of the restrictions? So this is kind of a challenge. And the other thing I think it's being discussed a lot now, vaccine equity. Obviously, there are so many healthcare workers who don't have access to any vaccine in other countries. So this is a major challenge. I as a clinician and researcher, I feel so bad knowing that some of my fellow, clinicians in another country have no access to any vaccine. So, this is something that we need to kind of build awareness kind of globally, I think.
How much efficacy is after the first dose of Pfizer and AstraZeneca?
So, I guess like for the efficacy in terms of hospitalization, all these vaccines have amazing protection, almost 100%. So
after the first dose?
So, after the first dose, it's about 96%, as far as I know.
Okay.
But in terms of like protection of symptomatic disease, it kind of differs from, kind of vaccine to vaccine. But generally, I think we need to kind of think that the first and foremost aim of the vaccine is to prevent severe disease and hospitalization. So that's the most crucial thing we expect these vaccines to do. And almost all vaccines have over 80% efficacy for protecting severe and severe disease and hospitalization. And when we look at efficacy protecting kind of milder disease, we know that, for example, Pfizer has around 95% efficacy. AstraZeneca has about 70 efficacy, but we know that WHO said and FDA said if it's above 50%, that's a good vaccine. So I guess like majority of these vaccine trials, we're looking at achieving 60% efficacy. So if it achieves 60% efficacy, that's overall a good thing.
So you can certainly, South Africa gave 1 million doses of the AstraZeneca vaccine, then stopped because they said it's not very effective against the South African variant. So does that concern you? Because that's a very easy vaccine to give to people because you don't.
Yeah.
Yeah.
I mean, I think so. Basically, what South Africa found is that when they have the variant, AstraZeneca did not provide enough protection against mild and moderate disease. Mm-hmm. So, but they were basically looking at really young and healthy population in that subgroup. So they were not able to ascertain whether it protects from severe disease. But majority of immunology studies looking at how AstraZeneca works in patients with the variant still shows there's a strong T-cell response, meaning that we expect, from a virology and immunology perspective, we expect this AstraZeneca vaccine to still work against severe disease and hospitalization. I totally understand South African researchers' perspective because, they have this variant, which is the dominant variant. They have almost all their cases is this variant, whereas in the UK we only have few number of cases with this variant. So it's a different scenario. But WHO vaccine group basically suggested that AstraZeneca could still be used in countries when this variant is circulating. Because as I said, the main aim of the vaccines is to prevent severe disease and hospitalizations. And we know that all these vaccines do that. And actually some data coming from South Africa showing that Johnson & Johnson vaccine, even with the variant, has 85% efficacy against severe disease and hospitalization, even though the presence of the variant decreases the efficacy against protection against mild and moderate disease. But as long as it prevents severe disease, that's the main aim. And again, like Novavax, it's highly likely that it will also prevent from severe disease as well. So I guess for other countries, even there's a variant circulating, I think any vaccine is better than no vaccine at the moment. So especially for high risk groups, medically vulnerable groups.
All right, so I have some questions, so I'm going to read them. So I live in South Florida. I am perplexed that the infection numbers and rate of infection are falling since there is less than 50% compliance on masks. Restaurants open inside and out. Gym, tourist areas are very crowded, little social distancing. Many of us were expecting an exponential growth in infections. How come this hasn't happened yet?
Yeah, it's difficult. I mean, I don't know exact reason, but I guess we need to kind of take many things into account. So, I mean, transmission depends on many factors. Although maybe there's not much compliance on masks, But maybe what's happening around the world is generally changing people's behavior. Maybe people are not really meeting inside much. I don't know exactly. But the other aspect is obviously we've kind of passed through the winter kind of peak time where, majority of kind of UK and many Northern European countries had their peak already. So maybe we're already on the downslope. And the other thing is it depends on how the percentage of the susceptible population. So, when you have more people infected, they will also develop some sort of immunity. And we know that, having had the natural infection, it protects, it provides the similar protection to having had the vaccine. So we see very, small number of reinfections after natural infection. But it really depends on, this epidemic dynamics are really complex. So it's so difficult to give an exact, cause why this is happening. But potentially multiple things are happening at the same time. And that's the reason.
Okay.
But
So
it's interesting. I really want to know what's happening actually in Florida, and especially, knowing that that's where this variant is also becoming dominant. So I think we need to watch and see what's going to happen. We will learn a lot, I think.
Well, Disneyland is there. Maybe there's some magical effect. I don't know. So are you concerned these vaccines been tested less than prior vaccines and drugs? And they're asking and the other question is, so when you talk about efficacy, what was the experience with the polio vaccine? How did that, compare to the efficacy of these vaccines? Okay, so the first question is, okay, all these vaccines are not approved. They're approved for emergency use authorization. So does that concern you?
Not really. I mean, some of the vaccines have been approved by EMA, so it's the European
correct, yes.
European agency. So basically, it's not only approved for emergency purposes. Actually, having had the EMA approval, that gives WHO to approve this vaccines for distribution globally. Because with the emergency approval, WHO cannot say these are safe to be given globally. So there are actually 3 vaccines now approved by EMA and not under emergency approval. So that's a good thing. But I think it's a bit difficult to compare the efficacy of these vaccines to polio. I'm not sure it's correct to do that, to be honest. Yeah. I think we need to look at what we're trying to aim with the vaccines in terms of COVID-19. So I think at the moment, the main concern clinically and biologically is to prevent severe disease and hospitalization, because that's what causing all the distress and basically causing hospitals to be overwhelmed, and that's been the main concern throughout the pandemic.
Okay. So someone asked, if someone has had the virus, should they get the vaccine or not get the vaccine? I think the FDA recommends you get the vaccine.
Yes.
Yes.
So, yeah. So, I mean, if you already had the infection, getting even 1 dose of vaccine, provides kind of a similar protection in terms of compared to getting 2 doses of vaccine. So at the moment we have, I think, 2 or 3 papers showing that, those who've already had a natural infection, when they get even 1 dose of vaccine, they have similar protection. So yeah, I mean, if you've had it, if you're in the, priority group set up by the government, or you're, you should get it.
So I read that people who have had the vaccine, people who have had COVID that when they get the vaccine, they get pretty sick from it. They start getting, the symptoms they had from COVID back.
I mean, I guess like it really, yes, I think I understand what you mean. Generally, what we've seen is that after the second dose, people get more kind of symptoms than the first dose. And I guess like if you've already had the natural infection, having the vaccine might basically create and develop more antibody response, and that may be the reason people have a little bit more symptoms. But what we've learned from all the vaccine distribution all around the world is it's not causing severe side effects. So majority of people have maybe fever or local symptoms, but it really gets better really quickly. We haven't seen severe, like prolonged symptoms after vaccination.
So let's talk about children a little bit. Okay, so far the vaccines are approved for people 16 and up. What do you think about, will children be vaccinated eventually?
Yeah, I mean, I think if the vaccine has been proven to be safe in children, and we know that AstraZeneca now is recruiting children to one of their arms, and so yeah, I mean, I guess at some point once we immunize and basically vaccinate the medically vulnerable population, I think it makes a lot of sense to vaccinate, especially medically vulnerable children. We know, for example, if they have underlying disease, like it could be respiratory disease or heart problems, they could be at higher risk of hospitalization. But luckily, we haven't seen much severe disease in children. But I think like once we pass through the stage that we are able to vaccinate the majority of medically vulnerable population, then we could go on to the group that we know kind of transmits more. And we know that, for example, teens, especially those over the age of 15, could transmit as well as adults. And because they have a larger network and have much larger social network, they could spread pretty quickly. And we know, looking at majority of like epidemiological studies, seroprevalence studies, older adolescents and younger adults are kind of mainly driving majority of infections, and that afterwards it just spreads around, to other age groups. But for example, for younger children, especially those less than 10, we know that they contribute, they get infected, they transmit. We know that there can be infections in the school environment, but relatively they contribute much little compared to other age groups. So I think we need to think about how we could prioritize things. And I think we also need to look at kind of globally. We wouldn't want to necessarily kind of vaccinate everyone in high income countries, but then there are still a lot of medically vulnerable population in low middle income countries. So I think all this needs to be balanced, and making sure that this is a global pandemic, and we can only get out of it if we are able to vaccinate majority of the vulnerable population in all countries.
So have children been going to school in Britain?
So yes, well, yes, no. So basically the schools were open from August till kind of December time, in all kind of developed nations, and it's been closed since Christmas, especially because of the concerns about the variant, and we had really high community infection rates at the time. So the plan is actually to get younger kids, especially those less than age 10, back to school from next week, in Scotland I could talk about, because there are still discussions in England. But there is a plan to get them back to school, and I think it's really been great that we prioritize opening schools in Scotland, especially like opening them and keeping them open. That's been a roller coaster and it's been difficult, but we know that kids have been affected really badly from school closures, not only because of education, but also from their social and social development perspective. And I think this really hit deprived communities most, and that's been really terrible. And we're basically seeing a lot of psychological problems, mental health issues in children. So that's been one of the priorities in Scotland, and that's something that I'm really proud of, I have to say. And hearing my colleagues saying that some schools have never opened in the US, even during low community transmission, it's so sad to see that. But I think it's been really difficult discussing about school openings. It's been highly politicized, and I think it's just, we can't necessarily have unbiased and observed discussions.
So where I live, there's a private school that's been open. It never closed. It's always been open. And some say, well, the rich kids, they can afford to do all the things to make things social distance. They can, the public school next to me, they're not open. And I know from friends, they say, I really want my kids to go back to school for their mental health, not only the kids, but the parents' mental health. And, like my daughter says, I want my daughter back in school. I want my husband back at work. She said that, it's tough, 24/7.
But I think it's just it's important that we have a lot of knowledge now, and we have a lot of evidence and experience from other countries. We've done a BMJ seminar. There were people from France, Norway, actually one researcher from the US. She basically said that what they've seen in states where they haven't opened the schools, they've actually seen more cases in kids compared to states where they opened the schools. Because the thing is, like, children don't get infected only in school environment. They also get infected from the family members. And if there's higher community transmission, there will always be chances for kids to get infected. But I think overall, we need to look at how opening schools have an influence in the community transmission. And we need to look at whether we could compensate that increase in community transmission by doing something else, and that's a fine balance. I'm not saying that kids don't transmit, and there's a risk that they may infect their, family members, but it's not 100% chance. It's not. I think many people think that if they go, if their kids go to school, their chance of getting infected is 100%. They think if they have, infected kid, their chance of getting infected is 100%. That's not the case. Even in the same household, the risk of getting infected is about 15%, 15 to 20%. So there are things that we could do to prevent infection within the school and also within the households. So, and it's never 100% risk, or it's never zero risk. Risk is a spectrum, and I feel that we haven't really digested this well.
Okay, so someone wants to know, have you had the vaccine?
Yes, I did.
Okay, and were you concerned about the fact that they're that they're relatively new and not tested? But I guess you addressed that really.
Yeah, I mean, I'm pretty confident that these vaccines have been tested, and they've gone through. Basically, we have a lot of data from phase 3 clinical trials. It's I'm actually a co-investigator on AstraZeneca vaccine, so I've been involved in the vaccine recruitment, and I followed some of the patients as well who had the vaccine. So the fact that I think we've seen really quick results doesn't mean that these trials have not been done properly. So I think it's just, we had quick results because there's been a lot of funding and many things have been much easier for researchers to do compared to other times. So I don't have any concerns about the safety profile of any of these vaccines. So if you're offered one, I think take it, especially if you're in high risk population for hospitalization and severe disease, just take it.
Okay. So once a person's vaccinated, how should they conduct themselves? Do they still have to wear masks? I think they do. Socially distance. I guess they have to still do that. But you're the expert, so you tell me.
So I think two things to look at. So once you're vaccinated, your risk of getting severe disease and hospitalization is almost really low. You don't. It's basically, it protects you from hospitalization 100%. The other thing is basically there's a still small but chance of being infected and being able to infect others. So I think this is the bit that gets a bit complex. And what we know so far is that once you're vaccinated, your risk of getting infected also decreases around 60%. That's what we know. But there's still a chance that you could get infected. And there's still a chance that you may be infectious. But because you already have antibody response, your infectiousness would be much lower than you getting, kind of primary infection. Does that make sense? And there's some data.
It does, yeah.
Okay, there's some actually data from AstraZeneca vaccine. They basically followed up patients and looked at how much viral load they have after vaccination when they get infected. And what they've shown is that they have much lower virus. So I think there's still a chance that you may infect others. So I think we still need to be kind of careful in kind of social encounters. And I'm still being careful overall. But I think, your chance of getting infected also depends on risk of exposure. So if you don't really involve in any other exposure, you don't see others, for example, your risk of getting infected will be lower. But I feel that, if you have a colleague or another family member who also got vaccinated, it may be possible to, have a much normal interaction. The other thing is, we know that it decreases hospitalization risk significantly. So I think people may need to do some risk benefit, discussion here.
So I had my second vaccine last Thursday. I had the Pfizer vaccine, and someone said, "Well, do you feel completely protected?" And I've read that the Pfizer vaccine works 7 to 10 days, but this is not really based on hard science. This is based on what they think. So I guess the bottom line is you wait 2 weeks and then you're fully vaccinated. Yes. I guess. Okay.
Yes, absolutely.
Okay. And I always get this question: when will the pandemic end? And we don't have crystal balls. I interviewed Dr. Moore at Cornell, and he said, I didn't get a crystal ball for my birthday this year. So he said, I don't really know. If you watch John Oliver this week, he talks about, they had a 60-minute show where someone was talking about, we're going to get a pandemic. And he said, we're going to get more because of things like deforestation. He talked about the Ebola vaccine was, in West Africa, and, a small child got it, and in an area that the whole, countryside had been just totally decimated.
Yeah.
And he said, we're gonna get a lot more pandemics. He said, and we've had one. We've had, talked about, the SARS vaccine, Zika, and all these things. So anyway, so I I always end up asking people what they do. So I guess so pre-vaccination and post. So do you do indoor dining? Because
Not at the moment.
it's cold in Scotland. It's cold. In,
Indoor dining, do you mean restaurants?
yes, restaurants. Yes,
I mean, they're closed at the moment.
they're
So,
closed. Okay.
yeah, yeah.
Because I've tried outdoor dining in New York City, but what they have heaters, but the seats are really really cold. It's not a great experience to be wearing a heavy coat, gloves, a scarf, and everything just to have a meal. So okay, so do you
Yeah,
see
I mean,
do you
in
see,
terms of the pandemic and when it will end, I think there was a really nice article from Nature the other day. They asked approximately 100 virologists and ID experts. I don't know whether you've seen it, but I think it's a really nice article. We potentially need to think about how do we envisage a long-term plan, because at the moment, COVID, SARS-CoV-2, does not necessarily fulfill any of the, predefined kind of key principles for a disease that could be completely eradicated. Because we know that there's an animal reservoir. There are a lot of animals that could be infected. And, if you have an animal reservoir, it's so difficult to eradicate and completely eliminate it, from every single country. The second thing is we know vaccines protect, but it wanes over time. So it's not like, the polio vaccine, which protects you, and it gives you complete protection, or like measles, where you get 2 vaccines and you're protected for your whole life. And the third thing is we know that it's so difficult to diagnose cases, and people can be infectious before showing symptoms, and that's one of the difficulty of completely eradicating a disease. So I think, as many of those ID experts said in that article, which I also agree, it will potentially become more like an endemic disease. Probably we will have like seasonal waves. And I guess like until the question is, until the majority of medically vulnerable population gets vaccinated, how we're going to keep the numbers low. And once they get vaccinated, how how do we envisage this future? What's going to happen?
so
So
do you
these are difficult
so
questions.
do you foresee that we'll be getting booster shots at some point?
Yes, definitely. I think so. I mean, at the moment, we don't know how long the vaccine gives protection, but we know that natural infection gives minimum 6 months or up to 8 months of protection, immunity after natural infection, and potentially vaccine protection will be much more stronger, and but it's potentially will require some booster, especially given the fact that we're seeing some variants, which may have an influence on the efficacy.
I believe Pfizer and Moderna are working on new booster shots that will cover these variants.
Yeah, exactly. I think
So
we may not necessarily require, completely different vaccine as we do for the influenza, but it may need to be kind of tweaked according to these variants.
But practically speaking, we can't even get enough vaccines to people who want them now. So how are we, so they said maybe by July we'll have, everyone who wants a vaccine can get it. So what's going to happen when the booster shot? I mean, the booster shots are going to take a while to develop, and we don't really know when to get them. And then the same problem is, everyone's going to want to get one. And so, so do you speak to the pharmaceutical companies? Or do they consult with you? I know you said you consult with AstraZeneca.
No, I'm just an investigator for
Okay.
AstraZeneca vaccine, but I don't give any consultation. Sorry, my battery is going to die. I'm just
Okay.
going
Well,
to plug it. Plug it.
okay.
Wait a second.
Okay. Go ahead.
Apologies for that. All right.
That's I've had one or two Wi-Fi issues during these things where it just that goes out, and so anyways,
Yeah, I mean, I think in terms of your question, so that I mean, I gave another talk discussing the vaccines, but one thing is that we need real-time kind of phase 4 trials. When we're rolling out these vaccines, we also need to do real-life clinical trials, and that's what we call, post-approval, real-world studies to understand how long the immunity and antibody response will last. And at the moment we don't have good correlation with how much level of antibody is enough. At what point we need to revaccinate or give booster, we don't know that. So I think this is just still an emerging area that we need to do a lot of studies. I mean, in the UK, we're doing a lot of like real-time studies, both in the lab and clinically, following up patients who've been vaccinated and understanding their transmission potential, and also like seeing what will happen in a year time, whether their immune response and antibody response will drop, and whether that means they're more likely to get infected. So I think these are still uncertain. There's still uncertainties. We don't know some of these, but I feel that people who are vaccinated this year, it will potentially be helpful for us for the next for this winter. So the most important thing is to think like maybe in short, medium, and long term. So in the short term, we want to get people vaccinated so they're protected from hospitalization. The second important thing in the medium term is to think about next winter. So what's going to happen in November, December? So we still want people to have enough immunity by then. And we need to think about long term, like what's going to happen in like 2-3 years time or 5 years time. So those are the things that I guess like requires a little bit more patience, acknowledging uncertainty, but also I think planning ahead, setting up these studies now, so we will have answers in kind of in 6 months time.
okay. So I want to just plug a little. So next Thursday, I'm going to be speaking with Sarah Bodie. She's a primary care pediatrician, and we're going to talk about opening schools. On Wednesday, March 3rd, we're going to have a conversation with investigative journalist Catherine Eben, who's going to talk about the FDA and their role in vaccines. And she wrote an article in Variety magazine, and she wasn't too happy with that. On March 11th, I'm going to shift gears a little bit and speak to Carl Zimmer about his new book called Life's Edge. And on Thursday, March 18th, I'm going to speak to Sherry Turkle, who wrote a book called Memoir, The Empathy Diaries. And all these books have gotten great reviews. Catherine Eben wrote a book called Bottle of Lies about the generic drug industry, which won prizes. So anyways, really want to thank you. I know you weren't feeling well, and want to make sure that your microphone is off.
Oh, thank you.
Okay.
Yes.
Okay. So I want to thank Dr. Cevik for agreeing to spend time with us, because she was not feeling well the last few days, and I hope you're all recovered now. And thank you so much. And where can people find your talks?
That's a good question. Yeah, I mean, I think I gave a couple of talks for the BMJ
Okay.
on transmission, one on schools. We also did a podcast talking about asymptomatic transmission.
So that
I
was,
also did some podcasts with Faye Flam from Bloomberg. She
okay.
has her independent podcast. I think now.
She's a member of our group, Science Rise in New
Oh,
York. So
right.
yeah,
Okay.
okay.
Yes. So
Yeah,
I did some podcasts with her. Yeah. I
okay.
mean, I guess maybe I need to put everything together on my university website so people
That,
could
that,
access
that,
to it.
that would be nice. Okay. Your university website was in the announcement. So thank you and stay safe. And I really appreciate you spending time with us.
Thank
And
you.
everyone
Thanks
out
a
there,
lot.
stay safe, and we'll see you next week to talk about opening schools. Okay, thank you and good luck. Bye-bye.